Hello and welcome to this 4-part educational series titled Hot Topics in COPD from Disease Phenotypes to Targeted Therapies. Each episode in the series will be dedicated to one of the following topics: the role of type 2 inflammation in COPD pathophysiology, current evidence for the use of biologic therapies in COPD, comprehensive evaluation of the disease and patient symptoms, and lastly, evolving treatment algorithms for COPD. I am Dr. Surya Bhatt. Thanks for joining me again, and let's get started. So there have been several updates to maintenance medications in the 2025 GOLD report. One of them is ensifentrine and the other is dupilumab, and both of these target different aspects of the disease. Ensifentrine is an inhaled dual PDE3 and PDE4 inhibitor that's only available in the United States. In the ENHANCE-1 and the ENHANCE-2 trials, ensifentrine was associated with a significantly improved lung function as well as shortness of breath. Quality of life was improved in ENHANCE-1 but not necessarily in ENHANCE-2, so there were some inconsistent results for quality of life. There was an unexpected exacerbation reduction signal in ENHANCE-1 as well as ENHANCE-2 in a patient population that was not enriched for high exacerbation risk. So these patients were on maintenance therapy in the majority, but in about 1/3 they were on no controller treatment. Some of them were on LAMA and LABA, and some of them were on ICS LABA, and no patients were on triple therapy. So this result suggested that ensifentrine can be used for control of symptoms in those who have uncontrolled shortness of breath. Dupilumab is a monoclonal antibody that targets IL-4 receptor alpha, which is the shared receptor for IL-4 and IL-13. And it is a monoclonal antibody that was tested in 2 phase 3 trials, BOREAS and NOTUS, for patients with frequent exacerbations while already on triple therapy. And both BOREAS and NOTUS showed a significant reduction in exacerbation frequency. BOREAS was associated with a 30% exacerbation reduction, and NOTUS was associated with a 34% exacerbation reduction. And both trials resulted in significantly improved lung function, approximately 83 mils in both studies, and a significant improvement in quality of life as well as daily symptom burden. Now, ensifentrine is administered in a nebulized fashion every 12 hours, and dupilumab is a subcutaneous injectable to be administered every 2 weeks. Now, where do these treatments fit in the treatment paradigm? So GOLD suggests that ensifentrine should be used for the management of uncontrolled symptoms as an add-on therapy, and suggests that we should consider adding ensifentrine in people on LAMA-LABA and continuing to have uncontrolled symptoms. Ensifentrine is not currently recommended for exacerbation reduction, mainly because it was tested in trials that were not designed for exacerbation reduction, and most patients in the trial were not on optimal standard of care controller therapy for exacerbation reduction. Dupilumab, on the other hand, fits in the exacerbation paradigm where patients who are on triple therapy and continue to have frequent exacerbations, especially when they have high blood eosinophil counts, and if they have symptoms of chronic bronchitis, dupilumab seems ideal for trying to decrease exacerbation frequency. In the previous GOLD report, in 2023 as well as 2024, the recommendation was that LABA-ICS no longer had a role in the treatment of COPD. But in this current report, there are some updates because approximately 50% of patients in the United States and a substantial proportion elsewhere in the world continue to be on LABA-ICS, and it was unclear how to manage these patients. So now there are some clear recommendations in the 2025 report on how to handle patients who are currently on LABA-ICS. So the recommendation is that if patients are currently on LABA-ICS and are not currently undergoing frequent exacerbations and they have a low symptom burden, then continue the same treatment. If they have a high symptom burden, even if they're not having frequent exacerbations, then consider escalating to triple therapy. If, on the other hand, you talk to them and find out that when they were started on LABA-ICS, there was no real relevant exacerbation history, then consider switching to LAMA-LABA. Or if patients are on LABA-ICS and you find out that they're having significant frequent exacerbations that are ongoing, then if their blood eosinophil counts are less than 100, then they're less likely to be responding to the ICS component, so it is prudent then to switch them to LABA-LAMA. And if the blood eosinophils are greater than 100, then consider escalating to triple therapy in the form of LAMA, LABA, ICS. There are also many interventional therapies that are described in the GOLD report and have substantial evidence for use. Perhaps the most common intervention therapy that's recommended in COPD is lung volume reduction surgery or bronchoscopic lung volume reduction. Increasingly, bronchoscopic interventions are being used for patients with COPD. In people with significant shortness of breath, especially in the setting of significant air trapping with residual volume at least 150 or 175% predicted, it is recommended that they be considered for lung volume reduction procedures. In those with non-intact fissures, surgery may be the only option currently, but in those with intact fissures, especially with heterogeneous emphysema, lung volume reduction procedures bronchoscopically can be done. In those with homogeneous emphysema and an intact fissure, bronchoscopic lung volume reduction can still be done, but with a slightly lower response in the form of FEV1 improvement and residual volume improvement. Several other interventions are being tested right now. For chronic bronchitis, we do not have any good treatments. Liquid nitrogen cryospray as well as rheoplasty bronchoscopically are being tried for the treatment of chronic bronchitis. For acute exacerbations, targeted lung denervation is being tested. As we move towards precision medicine in COPD, it is increasingly becoming evident that we need to accurately phenotype our patients and accurately endotype our patients. Phenotypes are currently in the form of frequent exacerbators or people with hyperinflation. Frequent exacerbators are now targets for potential biologic therapies, and hyperinflators can be targets for bronchoscopic interventions in the form of lung volume reduction. Endotypes are becoming increasingly important, so we now recognize the role of type 2 inflammation, and these can be easily checked in the form of blood eosinophil counts and also in the form of fractional exhaled nitric oxide, which is also shown to predict frequent exacerbations and may be a good indicator non-invasively of the presence of predominant type 2 inflammation. That said, the majority of patients still have predominant type 1, type 3 driven neutrophilic inflammation, for which we do not have any reliable biomarker right now, but many biomarkers are being explored as well as many treatments are being explored for this large subgroup of patients who frequently undergo exacerbations. So in summary, there are now new therapies for COPD, so I think it's especially important now more than ever before to accurately phenotype and endotype patients. In people with uncontrolled dyspnea in the setting of LAMA/LABA therapy, ensifentrine, which is a selective PDE3/E4 inhibitor, can be tried. In patients with uncontrolled dyspnea and significant air trapping, there are now interventional therapies that should be thought of and offered to our patients. In patients with frequent exacerbations, especially those with predominant type 2 inflammation, dupilumab, a monoclonal antibody, is now an option. Thank you for joining me in this Hot Topics program. You can view other episodes from this series on the landing page. For additional CME opportunities, clinical resources, and links to patient education materials, please visit us at www.exchangecme.com. Lastly, please remember to take the post-test and fill out the CME evaluation to receive your credit.